Perfect. All right, so we're getting started. I want to firstly thank everybody who's joining or who's watching the recording of this at a later time. But if you're not sure who I am, my name is Chris Caldwell. I am the Director of Marketing and Product Management for Best Buy Medical. Um, we'll jump right in today. I want to be cognizant of everyone's time. We are very excited to be partnering and presenting this webinar with Philips Respironics, highlighting the OptiChamber. This will give a chance for everybody who's not educated about the product to understand and discover how this innovative solution can support patients with both asthma and COPD. So again, I don't want to take the stage. I want to hand it over. Very happy to introduce Jason Cohen. He's the Strategic Business Manager for Sleep and Respiratory Care with Philips Respironics. So Jason, I'll let you take it away from here.
Thank you, Chris. Appreciate it. Let me just let me make this bigger. I'm going to turn my camera off. Okay, so let's begin. Maybe. So kind of where I wanted to start here is just on chronic respiratory diseases around asthma and COPD, specifically, how they're similar, how they're different. So in regards to asthma and COPD, they're both chronic respiratory diseases. There are some clear differences between the two. Asthma usually begins early in life, while COPD begins midlife or later. Early COPD often goes undiagnosed. Cases of asthma are mostly genetic, but there are, of course, environmental factors, allergens, for instance. COPD is cases from most of it is usually from long-term smoking, exposure to toxins, even childhood asthma or infections. Symptoms for asthma tend to vary, but mostly can be controlled. While COPD tends to be persistent despite treatment, symptom-wise, both could exhibit chest tightness, cough, dyspnea, which is shortness of breath. But the main difference with COPD, you do see much more sputum production. Lung and breathing performance can be reversible with asthma, but it's not with COPD. Treatment for both include the relief of symptoms through corticosteroids and bronchodilators. COPD treatment can also include oxygen therapy, positive airway pressure therapy or BiPAP therapy, antibiotics, pulmonary rehab, or even LVR, which is lung volume reduction surgery or valve replacement surgery. Sometimes actually even helps. So just around asthma and COPD in terms of its high prevalence, approximately 3.8 million Canadians, or 10.8% of the population, are living with diagnosed asthma. Children, asthma is particularly common among children, no surprise, with over 850,000 children under the age of 14 affected. Over 2 million Canadians aged 35 years and older were living with diagnosed COPD as of 2013. This represents about 10% of the population in this age group. The number of Canadians aged 35 and older living with COPD increased by 82% from 1.1 million to just over 2 million between 2001 and 2012 through 2019. Most likely the increase was because of better screening. It is suspected that in 2023 that 1.6 million people in Canada are undiagnosed, and that's according to the Lung Health in Canada. So let's talk a little bit about asthma. What is asthma? Asthma, in its most basic form, is an obstructive lung disease that inflames and narrows the airways. During an asthma attack, the lining of the bronchial tube swells, causing the airways to narrow. It reduces the flow of air in and out of the lungs, and that's what symptoms and that's what patients kind of experience, is that kind of that inflammation in the lung airway. There's no cure for asthma, but it can be controlled. One thing that patients like to say is they had severe symptoms when they were children, and as they got older, they say they outgrowed asthma, but no one really outgrows asthma. The underlying inflammation is always there. They just might not be symptomatic, and it might not be symptomatic for the rest of their lives. But that inflammation is always kind of there. Um, so around the goals of asthma, it's basically to reduce chronic symptoms, provide normal or near normal lung function activity levels, and reduce or prevent exacerbations. It's really important when it comes to asthma to prevent or reduce exacerbations. Severe and frequent exacerbations kind of lead to lung scarring, lung remodeling, and even could lead to COPD. Also, goals of asthma obviously are to reduce unplanned clinic visits and reduce ER visits, of course, to kind of keep costs down and impact on a child or family's life. So for COPD, COPD is a chronic progressive disease that can't be reversed. The goals of management of COPD are to manage symptoms and improve quality of life. Smoking cessation, obvious. That's the first thing that COPD patients should do if they're smoking. And it's obvious, but hard in practice. Really hard to quit smoking. Smoking cessation programs help. Medication, as we discussed before, bronchodilators are the first line, but also the use of corticosteroids to reduce inflammation, oxygen therapy, positive airway pressure, BiPAP are the kind of the most common therapies. Around COPD and adherence. So the hard truth about patients with COPD and other chronic diseases, for that matter, is compliance with therapy. In numerous studies on the topic, adherence falls over time. I'm sure that's no surprise to anyone. 60% of patients with COPD aren't adherent to prescribed therapy. 54% of patients with COPD stop their medications periodically over the previous 3 months, and 35% of patients with COPD don't use their MDI effectively. And there are many reasons for this. Complex medication regimens, COPD treatments can be complex and time-consuming, involving multiple medications and inhalers. The complexity can lead to confusion and difficulty in maintaining consistent use. Side effects. Some patients experience side effects from their medications, which can discourage continued use. Financial burden. Obviously, the cost of the drugs or physician visits and whatever are a big barrier. Lack of symptoms. When symptoms are well controlled, patients might feel better and they don't feel like they need to be using their medication. They tend to get lax, which leads to decreased adherence. Sometimes it's as simple as forgetfulness. They just forget to take their medication. And poor understanding of the disease. Some patients may not fully understand the chronic nature of COPD and the importance of ongoing treatment, which leads to inconsistent medication use. So where I want to go from here is I kind of want to talk a little bit about how aerosol delivery plays a part. What is aerosol delivery? Why it's advantageous to conditions of the lung. Actually, when it comes to targeting medication targeting, why it's important to target the lung. So aerosol therapy is the delivery of medication in the form of an aerosol into the target area of the lungs. It's the best drug delivery method for chronic lung diseases. Helps avoid hepatic first pass metabolism, which results in lower doses of medication required to obtain the same clinical response. Provides clinical response with lower side effects than many other methods, like, say, for instance, taking a pill or a shot. There's also rapid response after the medication's inhaled. Really important for a patient who has asthma or COPD, looking for some quick relief when they're exacerbated, having a little trouble breathing. The importance of particle size, that's really, really important when it comes to aerosol drug delivery. So particles that are smaller, less than 1 micron, lack sufficient mass and tend to be exhaled. Tend to think of the smoker when they exhale. You kind of see all that vapor. Particles above 5 microns deposit in the upper airways and don't reach into the small airways. So it's just drug that is just wasted. The particle, the kind of the Goldilocks zone of the particle size is you want to be between 1 to 5 microns. that's the size like a deposit reach and deposit into the small airways called the respiratory zone. As you can see from the picture here, 1 to 5 microns is where you hit those small airways, and that's what you're trying to target with aerosol delivery. So let's move on to how MDI medication adherence can support long-term outcomes. So there's kind of 4 treatment challenges that you experience as a clinician. Um, um, the first one is just belief that your asthma is under control, and many asthmatics believe their asthma under control. The rate of non-adherence among asthma patients ranges between 30 to 70%. There was actually a study done called the REALIZE study, that stands for Recognize Asthma and a Link to Symptoms and Experience. It was first of its kind, large multinational survey to explore the importance of asthma on patients' daily lives and their experience with the condition. It was aimed to assess how well asthma is managed and the level of awareness among patients about their symptoms, treatment, adherence, and overall control of their disease. Among other things, they found that greater than 50% of patients in the REALIZE survey did not use their preventer, which is their controller inhaler, every day as prescribed. Yet 92% were fairly or very confident about managing their own asthma. In other words, asthma patients tend to underuse their anti-inflammatory medication to control the underlying cause of asthma. Instead, they adapted to overusing their reliever, their rescue medication, to their worsening symptoms. So, kind of what, and none of this is kind of earth shattering. It's kind of what every clinician kind of figures it goes on with their patients when they're seeing that they're asking for a refill of their rescue med, more than every 30 days, or sometimes two or three times in a course of 30 or 60 days. Is that they're just not controlling, they're not using their medication correctly, is usually the culprit. Sometimes it's just the medication that they're using. It may not be right for the patient. You might want to try other things. But what's generally found, especially in this study, kind of what they found is like education. Education is the key to getting patients understanding the importance of their control of their medication and getting better outcomes. There's some patients that just like they think that they have just 2 types of rescue medication. They have their controller and rescue medication. They think they're both rescue medications, and they think one's just not working. So again, education has been found as kind of the key. The number 2 treatment challenge is improper MDI technique. And this one's kind of one people don't really think about, but it's a huge issue. Studies have found that 90% of patients have improper MDI technique. This results in poor asthma control, leading to decreased drug efficacy, increased side effects, and likely lower adherence, as well as greater use of non-planned healthcare utilization. I felt like this graph is a great graph to kind of show what happens with patients that use MDIs without a valve holding chamber. 90% of them have bad technique to begin with. The result is that only 9% of the drug actually reaches the lung. So essentially, they're wasting about 89% of the total medication output. Another reason, along with not using their controller medication, why many patients are puffing away, overusing their rescue inhaler, and not getting the proper control or the relief that they're looking for. So advantage and disadvantages of MDIs. There's disadvantages too. So the advantages obviously are they're portable, light, compact, multi-dose convenience, short treatment time, reproducible emitted dose, difficult to contaminate. Disadvantages, hand breath coordination is required, patient activation, and with that coordination, really, really important. Sometimes there's a reaction to propellants for some patients. There could be the foreign body aspiration if they don't keep the MDI clean, and high oropharyngeal deposition, or just basically a lot of deposition of the drug into the mouth or throat, again, when you're not using a valve holding chamber. Factors affecting MDI performance and drug delivery. shaking the canister. So not shaking the MDI canister that has been standing overnight decreases total and respirable dose by 25 and 35% respectively, because the drugs in the MDI formulations are usually separated from the propellant when standing. Therefore, MDIs must be shaken before first actuation after standing in order to refill the metering valve, which adequately mix the suspension from the canister. As you can see from the little graph here, you kind of see the actuator nozzle, the actuator seat, the metering valve, and where the drug is. So where the metering valve. So when you're priming it, that's kind of what happens there. You prime it, and you get your drug kind of formulation correct. Timing of actuation intervals are also really, really important. Rapid actuation of more than 2 puffs with the MDI may reduce drug delivery because of the turbulence and the coalescence of the particles. A pause between puffs may improve bronchodilation, especially during asthma exacerbations with episodes of wheezing and poor control symptoms. Recent literature also supports a pause of 1 minute between actuations for effective aerosol therapy. And again, just about priming. Priming is releasing 1 or more sprays into the air. Initial and frequent priming of MDIs is required in order to provide an adequate dose. Again, the drug may be separated from the propellant or other ingredients in the canister and metering valve when the MDI is new or has not been used for a while. Because shaking the MDI will mix the suspension in the canister, but not, where you see that, not what's in the metering valve. So again, really important to shake part of it and prime it. Characteristics of the patient that also plays a part. Using the MDI will result in variability of aerosol deposition. So, for instance, like if you have a very young child or an infant or an adolescent, the therapeutic range of that child is obviously much different than that of a grown adult, right? So that also plays a part in terms of the amount of drug the patient is getting, the therapeutic response, as well as how their lungs are developed. So again, plays a part. So next, let's talk about what's the difference between a spacer and a valve holding chamber. So what's the difference? A spacer is a generic term used to describe a tube-like accessory that extends the mouthpiece of the inhaler and directs the medication towards the mouth. A valve holding chamber is a spacer that contains valves to hold the aerosol for a short period of time. The valves open to release the medication when you breathe, improving drug delivery due to time delay, coordination, or sometimes in the event of incorrect mouth or face mask placement. Why is a valve holding chamber important? What's important about choosing the right valve holding chamber? So if you remember from one of my earlier slides, only 9% of the drug when using an MDI alone reaches the lung. The rest ends up in the mouth, stomach, upper airways. Valve holding chambers help reduce side effects. It enhances your treatment. A valve holding chamber may improve drug delivery in the lungs, where it's needed, by up to 4 times than that of just the MDI by itself. Lastly, it simplifies and improves coordination. It's probably that's the big differentiator why I use a valve holding chamber. With a valve holding chamber, not only are you making more fine particles available, it stays suspended within the chamber, making it available for patients with poor technique, time delay, or highly exacerbated patients with shallow breathing needing multiple breaths to clear the chamber. The use of valve holding chambers are supported by a number of guidelines. 2 key ones is the GINA guidelines recommend a valve holding chamber with any asthmatic taking corticosteroids to improve fine particle dose and reduce side effects. The National Institute of Clinical Excellence, which are the NICE guidelines, recommend for children under 5 should use a valve holding chamber with or without mask where necessary, because it improves drug delivery with poor technique and time delay. Some valve holding chambers, like the OptiChamber Diamond, that I'm going to detail to you today, have some additional patient benefits, such as the ability to use a face mask, important with patients that can't create or maintain a mouth seal around the mouthpiece. One-way valves, anti-static material, improve one-way valves and anti-static material both will improve the amount of drug that stays in the chamber and the amount of drug that stays suspended for and made available to the patient to breathe in, as well as flow whistles that reinforce slowing down breathing, that decreases mouth and throat deposition, to name a few. So going into the next treatment challenge is number 3, and this one is just about poorly fitting mask. So a poorly fitting mask can have a significant impact on drug delivery. If you don't fully seal the face with the mask, incoming air will follow the path of least resistance, which will be through the gaps in the face mask, and less will be drawn through the chamber. So kind of what happens is the drug will rain out in the chamber while air is drawn into the lungs through the gaps in the mask, decreasing deposition. Even a 1 centimeter gap in the face mask seal can result in a loss of upwards of 50% of the dose. As well, utilizing a comfortable mask minimizes the force to create a seal, which is optimal. So the more comfortable the mask is, the better it seals, the more likely the patient's not going to pull away, cry, or thrash around, where then you start getting those significant gaps in the face mask. You're fighting to give them a treatment. And treatment challenges 4, basically if the patient won't or can't use an MDI, it could be because of cost, it could be because of the you don't have the right drug in an MDI formulation. It could be due to dexterity or understanding how to use. So basically, when all else fails, the recommendation is to try a nebulizer to see if results are more favorable. So now let's go into OptiChamber Diamond specifically. So the OptiChamber Diamond, made of anti-static material, which helps keep medication suspended longer, designed to allow more medication to be delivered into lungs, ability to be used with most commonly prescribed MDI inhaler medications that are on the market today. Includes a stepped-up mouthpiece that can be used by both children and adults. Discreet, portable, and small enough to carry in your handbag or child's school bag. And at least in the US, it's a #1 preferred brand of spacers for pharmacies. In terms of the features of the OptiChamber, so has a high visible expiratory valve, helps measure breath count and breath hold. Flexible MDI adapter secures the MDI straight and in place. Integrated flow whistle helps teach patients to slow down their breathing to take slow, deep inhalation for better drug deposition. Like I mentioned before, anti-static material. The stepped-up mouthpiece facilitates transfer from a mask to a mouthpiece for children with small masks, and tethered cap to make sure you don't lose it. It also has a flat bottom, so it doesn't roll off the table. It comes completely apart for cleaning, and it has a 1-year warranty. We're the only spacer manufacturer that actually offers a 1-year warranty on their valve holding chamber that I'm aware of. A little bit about the face mask specifically. The face masks feature a soft seal technology with contoured silicone cushioning for comfort and effective seal. 3 sizes from birth to adult. We don't need 4 sizes, we feel, with our masks, because we have very low dead space the way these masks are designed, and how well the mask seals with that soft kind of light touch seal around the hard shell. The masks are also detachable for progression into the mouthpiece. So for a patient that may say they start with a medium mask and they no longer need to use a mask, you don't have to get a different product. They can just transition right to the mouthpiece. Or if maybe they're using a small mask and they need to transition to a medium mask, they can just get a mask. So it helps keep patient costs down. The product as well as the mask have a transparent plastic for clear visibility of the patient's breathing, as well as with the mask in their face during therapy. Mask has standard color coding for easy sizing, yellow, orange, and blue. And kind of in terms of benefits, it's called a light touch mask because you only need 1 pound of force to create a face seal. So it makes it just more comfortable. Most masks on the market require at least 4 pounds of force, so a big difference. And the more force you put on the face, the less, like I mentioned before, the more likely that the child is gonna fight you with it, which is going to lead to gaps, which means a lower deposition and rain out in the chamber. So now let's go into step-by-step use of MDI with valve holding chamber. So prior to use, examine the device for damage or missing parts. Remove any foreign objects or debris from the device. An optional mask if you happen to be using a mask. Do not use the device if parts are damaged or missing. If the MDI is new or hasn't been used for several days, prime it by pointing it into the air and actuating the device 1 to 4 times according to the IFU instructions. And instruct the patient to wait 1 minute between breaths before they take their next actuation to make sure that the meter dose is the MDI is properly primed. From there, using the MDI with a valve holding chamber is documented in our IFU and our instructional sheets. It's pretty step by step. Just remove the caps from the inhaler in the chamber. Insert the chamber into the back of insert the inhaler into the back of the chamber. Shake the chamber according to the inhaler instructions. Basically, you usually just shake the chamber for 10 or 15 seconds. Place the lips around the mouthpiece, form a tight seal, and exhale. Spray 1 puff of medication and immediately slowly inhale, taking a deep breath. Hold your breath for at least 8 seconds or as basically as long as you can. If you're breathing in too quickly, the flow whistle will go off telling you to slow down your breathing. If using a mask, place over nose and mouth, spray 1 puff of medication and maintain seal for 5 to 6 breaths. You really don't need to hold it that long, but you just don't know how exacerbated or what age the child is, or if they're really exacerbated or they have really shallow breathing, need to take multiple breaths. So 5 or 6 breaths, every patient will definitely be able to clear that chamber. And then in terms of cleaning, take the device completely apart, agitate parts in warm water for 2 minutes, soak for 10 minutes in warm soapy water, rinse it, and just let it air dry. Now let's go into some OptiChamber clinicals. Just want to touch on just a few. This first study I'd like to present here. It was done by Ditcham et al. And is an in vivo study on lung deposition with children with asthma, utilizing a spacer and spacer with mask. The objective of this study was kind of to determine if inhalation via the mouthpiece is more efficient than inhalation using a face mask. The background here is that inhalation via spacer mouthpiece has been shown to be much more efficient than an MDI with spacer used with a face mask. Generally speaking, face mask, again, because of gaps in the face mask and dead space in the face mask, generally you're looking at a reduction of fine particle dose of like 20-25% on average generally what they've found utilizing a manufacturer spacer versus utilizing a manufacturer spacer with mask. However, with the OptiChamber Diamond with the light touch mask, what this in vivo study has found with asthmatic children, so it was a live study done with asthmatic children, it was found that because the light touch mask seals so well, the difference between using a spacer mouthpiece with face mask from using just the spacer, the difference is only 4.4%. Typically, again, you see between 20 and 25%. So kind of what this shows you is that with the OptiChamber light touch mask, you don't have to be in a big rush to try to transition the patient to the mouthpiece to try to get better drug delivery. You're getting really great drug delivery on par with just using the spacer when using a spacer with mask with the OptiChamber light touch mask configurations. The next study I wanted to detail to you guys was the Dr. Slater study. This compared the effect of inhalation delay and flow rate on emitted dose from 3 valve holding chambers. In this study, they looked at how the OptiChamber performed versus AeroChamber's Z-Stat FlowView and AeroChamber Plus with patients with poor technique. And in this study, they measured the delay of 0, 5, and 10 seconds. And the delay is with the actuation of albuterol and delivered at different flow rates of 5, 15, and 30 liters per minute. And they utilized 27 different combinations of inhalation delay, flow rate, and valve holding chamber brand. The conclusion was that at the longest time delay of 10 seconds, OptiChamber and Z-Stat performed the same in terms of mean emitted dose, while OptiChamber performed better at shorter delays of 0 and 5 seconds, demonstrating that the better the patient technique, the better the OptiChamber performs. At worst, performance was as good as AeroChamber Z-Stat and better than AeroChamber Plus, even at the longest time delay. And then kind of the third study I just want to mention was the MIA study. They looked at the optimal amount of medication force necessary to create a seal. The lower force needed to be more comfortable, which is what they were looking for. What was the lowest force that could create a seal that was most comfortable, so that children will find therapy more receptive to therapy. This study was done with 30 asthmatic children, and kind of what they found in this study was that that you only needed 1 pound of force to create the mask seal with the OptiChamber and light touch mask, versus the AeroChamber Z-Stat and with FlowView required 4 pounds of force, creating the same seal. So, like, in conclusion, the differences between the two products, I thought it'd be good to kind of go over. In terms of OptiChamber with light touch mask versus the AeroChamber Z-Stat with mask, seal confirmation and breath count, they both have the ability to count breaths. Anti-static chamber, they're both anti-static, while the OptiChamber does have an anti-static mouthpiece if you happen to be using the mouthpiece instead of the mask. Drug deposition without a mask, with OptiChamber, it's higher. The average 18.1% higher fine particle fraction with the face mask than AeroChamber, and the OptiChamber Diamond versus OptiChamber Diamond with mask only had a 4.4 difference in the amount of dose delivered, while the AeroChamber had a lower deposition when using the mask. Flexibility-wise, the OptiChamber mask detaches, it grows with the patient. The AeroChamber does not. You would have to, if you need a different size mask, you have to buy a whole new configuration. Flexibility, in terms of forgiving with time delay, they're both forgiving with time delay. OptiChamber is superior at 0 and 5 second delays and equivalent at 10. Face mass force, you only need 1 pound of force to create a seal with the OptiChamber versus 4 pounds with the AeroChamber. Warranty, we do offer a 1-year warranty on our product. Young children mouthpiece adaptability, we do have that step up mouthpiece, making mouthpiece delivery more comfortable to smaller mass geometries. And trach adaptability with the OptiChamber. It's kind of nice that if a trach patient needs to take a MDI treatment, you just use a 15-22 millimeter step down adapter and you're good to go. You don't need a whole separate product. Cleaning comes fully apart for easy cleaning. And chamber, like I mentioned before, we have 3 sizes. We only need 3 sizes versus carrying four sizes or 4 different SKUs. And that's it. I'm going to kind of open the floor here to any questions anyone might have.
Thank you very much, Jason. That was very, very informative. So, as you said, we can wait on a question. I will, while we're waiting, I will let everybody know that this webinar will be available as a pre-recorded video. If anybody on your teams or your colleagues do want to see this information, I know there's a lot of valuable information in there. We've also, for anybody that's here, if you navigate under the materials section, we have our internal our directory for our territory managers for Best Buy Medical. So after this is all over, if questions come up or product availability or anything like that, feel free to reach out to your designated rep. But again, Jason, I want to say thank you very much for that. Much appreciated.
Thank you, Chris.
I don't see any questions coming in yet. We'll wait another moment, just in case. I don't see any, but so I'll just reiterate again. Feel free. Anybody out there that has any questions that they want to forward along to their territory managers, feel free. We'd love to do everything that we can to support. We are excited to now be offering the OptiChamber and the Philips products. Great partnership. So, with that being said, Jason, I want to say thank you again. Much appreciate having you on here to share the information.
Yes, I want to thank the attendees for being here. Thank you for your time. Appreciate it. Thank you.
Awesome. Perfect. Thank you, everybody. Farewell.